Hello, my name is Matthew Patrilla. I am currently a master's student in nursing here at Mount Mercy University. This is my capstone project for class NU660, and the title is Decreasing Discharge Times After Total Joint Replacement. I completed my capstone project at Mercy Medical Center in Cedar Rapids, and I completed it working with total joint replacement patients in the pre and post setting. After meeting with my clinical preceptor, Molly Newhouse, I determined that hospitals need to discharge patients quicker after total joint replacement surgery. This is for a couple different reasons. Discharging these patients quicker will allow for more surgical admissions to follow. It will also decrease the need to hold patients in recovery while waiting for an inpatient bed, and it will increase overall patient satisfaction since the patient won't have to sit around waiting for discharge. When conducting my literature review and searching for evidence-based practice, I conducted that research through EBSCOhost, Medline, and PubMed. I found that patient education can and does contribute to decreased length of stay. Both pre and post-operative education needs to include the patient's caregiver, be that a professional caregiver, a family member, or a spouse. Early and often mobilization of the patient post-operatively also contributes to decreased length of stay. Many factors are found to be associated with greater mobilization. This includes younger age, patients of the male sex, patients with lower BMI, patients who received spinal anesthesia preoperatively, or patients that are getting increased pain control through analgesics after the surgery. Also, symptom control, including decreased nausea, numbness, lightheadedness, and drowsiness. Those factors there have been found to decrease patients' ability to mobilize. Also, patient readiness for discharge has been found to increase lengths of stay. It is important to note that not all of these factors are modifiable. Through the completion of my project, I came across a few gaps and barriers. I found that patients are not being assessed for possible deficits preoperatively. Staff documentation of ambulation, including time, distance, and activity during that ambulation, has not been documented with regularity, thus making it hard for me as the researcher to find what I needed to find. Physical therapy is evaluating the patient at various intervals after arrival to the floor. This needs standardized to be of importance to anyone looking at this variable for information. Hospital resources are also in short supply currently. This includes staff as well as time. They go hand in hand, as if there is not enough staff, then they do not have the time to devote adequate attention to each patient to get them discharged in a timely manner. Varying degrees of patient readiness for discharge is also a barrier, because not all patients are ready to leave the hospital. I found this to be especially difficult to glean from chart review. Physicians are writing discharge orders at different times during the hospitalization as well. This needs to be standardized as well. Without standardization of this variable, this is a hard or difficult metric to look at, because it nearly negates the time it takes from order to discharge of the patient, since that can vary widely depending upon when the order was placed. Also, meetings that were held for this particular committee about patient discharge were held at various times during the day. They were held infrequently, and sometimes they were canceled last minute. So that left me relying on meeting minutes and also secondhand information. Plans for this capstone project was chart review to attain patient age, gender, surgical procedure, time of arrival to floor, time until ambulation, distance of ambulation, and discharge time. Also, interviewed orthopedic unit manager to determine current workflow for ambulation and discharge. Interview pre-admission surgical evaluation, or PACE, regarding current practice. I also performed a job shadow for a few hours to see their workflow, ask questions, and look at the literature that they give their patients. Also, I identify need for improvement as it pertains to patient discharge. Finally, I wanted to implement preoperative screening tool to help identify patients at risk for delayed discharge. To implement this plan, I decided to come up with a screening tool that PACE could use preoperatively to possibly flag patients as being at an increased risk for late or delayed discharge in the form of decreased ambulation. Remember those characteristics and factors that are associated with greater mobilization that I talked about earlier in the literature review. I wanted to focus on age, gender, BMI, history of post-op nausea, vomiting, and also, do you live alone? Meaning, what does your support system look like once you're discharged from this hospital? For age, I divided it at 65 years. 0 points awarded for under 65, 1 point awarded for over 65. Gender, 0 points awarded if they were male, 1 point awarded if they were female. For BMI, I split it at 30, which is the nationally recognized cutoff for obesity. 30 for under 30, or excuse me, 0 awarded for under 30 BMI and 1 awarded for over 30 BMI. If the patient has a history of post-op nausea vomiting, they got 1 point. If not, they got 0 points. And do you live alone? They got 1 point for yes and 0 points for no. If the patient received a score of 3 or higher, PACE will then notify physical therapy, the orthopedic nurse practitioner, and the supervisor on the orthopedic floor that the patient is potentially at a higher risk of needing more assistance with postoperative needs, including ambulation and symptom control. At-risk patients will then receive more resources focused on timely discharge and also ambulation. To go with this, I educate staff and management regarding the importance of decreased discharge time amongst total joint replacement patients, educate staff and management on patient variables that can lead to decreased discharge time, and integrate teaching on the importance of patient readiness for discharge into all phases of patient teaching. To evaluate how well this project worked and whether or not it decreased discharge time, I need to interview the PACE staff regarding ease of use and any improvement ideas they may have, interview physical therapy, the nurse practitioner, management regarding thoughts and feelings on patient readiness post-implementation. I need to interview management on what is working and what isn't working as far as flagging patients for more resources. I will then need to run reports on discharge times to look at the numbers to see whether or not they are getting discharged, they meaning the patients that have been flagged. I also need to review patient satisfaction scores, paying close attention to any information regarding discharge. Finally, the chart review will focus on discharge times of the flagged versus non-flagged patients to see if there is a difference or a trend emerging. Thank you for listening to my poster presentation for class NU660 and my capstone project. I hope you enjoyed this presentation.